Welcome to the Advances in Research and Innovation stream at the SNOMED CT Expo 2025. Thank you to Daedalus for sponsoring this stream. My name is Peter Groves-Williams and I'm a technical specialist with SNOMED International. I'll be your moderator for today's session. We'll address all questions at the end of the presentation. For our online audience, please use the Q&A button to submit your questions to the presenter. For those attending in person, feel free to use the microphone, which will be provided in the room. Over there, super. It's now my pleasure to introduce Mark Helbert and Ilse Hoffman from SAS, who will be presenting Closing the Gap Between Narrative and Structure, a workflow integrated documentation improvement tool for enhancing SNOMED CT-coded problem lists in hospital practice. Mark and Ilse, over to you.
Good morning, everyone, and on behalf of SAS, which means Ziekenhuis aan de Stroom, Hospital by the Stream, we'd like to welcome you to our hometown of Antwerp. We're going to present to you today a tool we've made to improve coding, make a coded problem list in clinical practice. So we're going to go through what is the relevance of a problem list for clinicians, what's the problem with the problem list, what's our proposed solution, what is the performance, what are the results, and what are our next steps, where do we want to go with what we've done so far. So what is a problem list? Actually, a problem list is, the concept of problem list has already been started way before there was even talk about SNOMED. So actually a problem list should function as the core of a health record. It should be an overview of all relevant medical problems, procedures, complications, and visible at first sight. As soon as you open a file, you should have an overview of what's relevant for this patient. It should be updated because not everything that it's in there will remain relevant. New diagnoses, new issues should be added. Things can get cured, things can become passive. It should act as a compass in supporting targeted and systematic clinical thinking and working so that you can make the right decisions based on a full view of what's your patient, and then add it. If it's coded, I probably don't need to tell this audience, but then you have a semantic interoperable system where you can also go share data across health records and across hospitals, hopefully. And that's how you really can use the system and make optimal use of it. So here you see an example of a problem list to the left, where, yeah, it doesn't have to be coded. This is just a problem list, and you can immediately also spot some issues like the lowest line, bleeding anus from 2018. There's no specific diagnosis there. You can doubt whether this is still relevant. And also if you look at the upper part, there's two listings at the same date of a viral gastroenteritis, where once there's noted that it's due to norovirus and once it's not noted. So it's a problem list, but it's not fully updated, but it's already a great start if you have something like this in your health record to start with.
So what's the relevance of a problem list? The problem list is relevant from different points of view. First, it's relevant to our hospital as we are, as most hospitals, committed to high quality registration as a part of high quality care. And we consider the problem list to be a central part of this. It's also relevant at the national level as semantic interoperability of key clinical data elements, including diagnoses and procedures, was defined as a strategy of the Belgian government and Ministry of Health. At the EU level, having a structured problem list is what a hospital needs to be prepared for the EHDS regulation, which actually will oblige problem list exchange for primary and secondary use as it contains the EHDS priority data elements, obligation from 2029. And finally, the problem list is relevant to us clinicians and to the CMIO network because we as clinicians consider keeping it accurate and up to date to be a challenge for us clinicians, and we need to find toolings and practical solutions to be able to reach this goal. So what is the problem with a problem list? You can, of course, assess the quality of problem lists in various ways. And the figure to the left shows, for example, quality of problem lists in our hospital, which clearly shows that overall of the 5 million problems that have been documented in our hospital, approximately 84% of them are coded and foreseen by a SNOMED CT code. The figure on the right shows that different specialties do not all perform equally well in performing this task, but nevertheless, overall, an 84% score is not that bad. However, if we look at the real problem, that is that often we see that new problems typically do end up in consultation letters or in discharge letters, but often do not find their way into the structured list of problems. The underlying causes for that are multiple. First of all, it's because it's registration burden for the clinician. There are insufficient processes supported to accomplish this task within most EHRs. There is also a problem of unclear responsibilities within a multidisciplinary approach of a patient by several clinicians on who is actually the person that needs to register the problem within the problem list. And finally, a very important problem is that the effort, there is effort, but there is not yet really a what's in it for me for the clinician. So that means semantic interoperability is not yet giving real advantages to clinicians. Of course, this problem with a problem list results in problem list quality issues, problem lists being incomplete, incompletely structured, and not up to date. And that has a very important impact on the service value of that problem list for both primary and secondary use. And it risks creating a vicious circle effect, because if problem lists are not being updated, clinicians will not see them as the source of truth for the patient in the EHR and will not want to invest in that problem list. The other challenge.
So here we want the other challenge. It's not just your EPD, as we said, but also the European Health Data Space. And early 2029, we start with the first group of categories that have to be able to be interchanged in the EHDS, and one of them is, in fact, patient summaries. And then we, from ZAS, we did a query asking other Belgian hospitals how ready they are, how they deal with SNOMED coding, how far they are, and you can see the results are quite disappointing, that almost 2/3 of them yet have to start, and more than half don't even have a clue what is SNOMED coding actually doing and how to start to implement it. So where can we find a solution? Well, the main thing is we need to help the clinician to do the coding, because data start at the source, and the source is your clinician. So we wondered, can we use large language models for automated SNOMED CT-based problem list maintenance? The idea being, you as a clinician, you do your consultation, you write your discharge or consultation letters, and there you normally will write down which diagnosis you have made, and then you could start extracting the problems in real time. Of course, often things will be mentioned, especially with chronic patients that are already in the problem list, so you want to compare the new concepts with what is already in the problem list. That way you can create a delta. That delta will be offered to the clinician, and then the specialist will have to validate, because the system is not error-free. The clinician will have to validate whether you indeed want this concept added to your problem list. So we want to integrate it in a clinical workflow. We also wanted it to be a health record system agnostic, so that it can be added to different patient record systems. And of course, we want it to be compliant with national and European interoperability standards, because that's the whole scope of the thing, also making it shareable later on.
So graphically, the workflow concept is as follows. The yellow square is actually the letter that the physician is writing. And at the time of writing, the pink square is the problem list as it already exists within the EHR. What the tool does is it analyzes real time what the clinician is writing in his letter or in his letter conclusion, compares the extracted diagnoses or procedures with those that are already in the problem list, and then confronts the clinician real time with what is shown in the third blue box, which is a list of proposed new problems with some metadata elements present. And the clinician can then real time validate these lines, and if he validates the lines, the tool will automatically update the problem list with the validated lines. This is more detailed, the user interface with which the clinician will be confronted. So the tool actually presents 3 categories of problems: the suggested new problems, shown as 1, the problems that the tool that extracted from the letter but were already known, number 7, and the clinician also has the possibility, if he wants, to add some additional problems that he maybe did not add or mention in his letter. The different metadata elements, such as laterality, status of the problem, and end and start date, are also mentioned and will be shown if they could be extracted from the letter. They can be edited by the physician if he wants to do that, or he can also correct them should they not be correct. This shows you a view of how we see the tool integrated within an EHR system, where you see the tool is now central in the blue box. It's the list with which the clinician is confronted. Next to that, the pink box is the current problem list, so we can also compare with that. And in the yellow box, he can see the conclusion which he is writing or has just written. So he sees the 3 elements in parallel. For all the technical aspects, to say model training, LLM workflow, SNOMED CT embeddings and code selection, retrieval augmented generation, and technical integration with the EHR, I would like to refer to the talk of Giulia Baldini later today between 15:30 and 16 hours, also in this same room.
So how did we do the project? We actually started thinking and preparing it early this year. Then we had a phase, quite intense phase for the clinicians of annotation, so where we reviewed around 1,000 letters, mix of in and outpatients and different specialties, where we really trained the system. This is the conclusion in the letter. This is the things we want to see coded already in the problem list, not in the problem list. Then we have a clinical validation round, first on a smaller number of patients, 50 cases, 2 specialists. And once we were happy with this first proof of concept, we did a more extensive validation, and then again scoring in all 6 specialties and 350 new letters. And that was also then used to start training for a 7th specialty, being geriatrics. And as you see, most specialties were internal medicine, so we wanted to see whether it worked on a different specialty as well. In August, we started evaluating, and we hope to go live with it very soon, so November, December. We would like to extend to other specialties and validate in other Dutch, we're from the north of Flanders, we speak Dutch, validation in other Dutch hospitals from the Netherlands, but also see if we can use it in Belgium, in the southern part where they speak French, so where French letters will have to be analyzed.
So what were the results of our clinical validation? Validation performed by clinicians of the specialties for which the tool was trained. So what was the performance of the tool? We look at different performance dimensions, the first one being completeness or recall. Completeness is the percentage of relevant concepts which are actually present in the letter that the tool correctly identified according to a clinician. We also looked at accuracy or precision. Accuracy or precision is the percentage of concepts that have been put forward by the tool and that were actually present in the letter, again, as assessed by a clinician. We also assessed the correctness of SNOMED CT mapping, which is an assessment by the clinician of how good the SNOMED CT concept that was found by the tool was for the concept that was actually put forward. This could be scored as very good, partially good, or incorrect. And finally, the most critical key performance indicator was the semantic accuracy, which is the percentage of concepts identified by the tool actually present in the letter and assigned a correct SNOMED CT code as assessed by a clinician. So the results for performance, you can see that completeness and accuracy were respectively 90% and 93%, which were actually over the target KPIs we initially wanted to reach, and they are more or less the same for all the different disciplines. Regarding SNOMED CT mapping accuracy, we found a score of 92% good scores, 2% acceptable, and 5% wrong. And finally, for the most strict criterion being semantic accuracy, we found over all disciplines an accuracy of 90%. So what are the next steps? First, we assessed compliancy with the MDR regulation and the EU EAI Act. This is not considered a medical device and it is not considered a high-risk category tool according to the AI Act. We are now confirming these KPIs, which were performed for the 350 letters from 7 disciplines, but within one and the same hospital. We are now confirming this for letters coming from other hospitals, and we have done this for one hospital, and the KPIs are similar. We are working on EHR integration with one EHR vendor at this moment to be able to have this really good workflow integration for the clinician, as this will be very important in clinical buy-in. We plan a small scale go live end of this year with the 7 specialties for which the tool has been trained to really prove that it has real life clinical value in a real life clinical context. In the meantime, the model is being improved in terms of speed and performance, and we are extending the model training to, from now, 7 disciplines to eventually all 40 medical specialties which are present in SAS. And we are also planning on extending functionalities. For example, we also want the tool to eliminate doubles in problem lists and other things like that. And with this slide, I'd like to close our presentation and open it for questions.
Thank you very much, Mark and Elsa. Can we take some questions from we have 5 minutes for questions.
Thank you very much for this beautiful layout and very smart facility that you have invented. I can see that it seems that you have a system that is very efficient in named entity recognition and linking to SNOMED CT, which we know is possible from many other projects. However, I want to ask you about the granularity, because you say that you want to have this system to be able to discard doublets of problems. And with the granularity we have in SNOMED CT, I would expect that a lot of this would be children of other problems. And where do you think you can find the definition of what is a duplicate and what is not a duplicate? And I think that is that would, as a clinician, I would say that is a really, it must be considered, because otherwise it will not be thought of as a wise decision to delete or add new problems.
Yeah, I think that's indeed correct, but the way we approach it is, of course, that the model is being trained by clinicians. So it's the clinician that indicates if the model should consider something as a double or not. And that's the whole concept, because we didn't really stress that, but certain diagnoses will also maybe be not so relevant for certain specialties, and they will be relevant for other specialties. But that's why we use clinicians from those specific specialties to train the model on how it should act, so it should think as being from that specialty that it works for.
Yes, thank you for your presentation. I'm here. Sorry. Just if you think to surgical specialties, do you think your model would be also so accurate for surgical specialties, because it's rather procedures and it's different from and also do you think the 90% is enough if it's above the KPI, but is it enough for clinicians, for what's the response of the clinician you talk with? Thank you.
Okay, for the surgical letters, indeed there is a challenge, because those are not always structured in a way that internal medicine letters would be structured. First of all, we consider for those letters of analyzing the total letter instead of only the conclusion. And indeed, it's something we are going to see. We are going to start training surgical letters, and for some surgical disciplines, it's also different than for others. So it will be a challenge, but we do think there will be quite some possibilities. Your second question was the 90%. Well, this is of course a first step. We are sure that we can still optimize. And I do think that even if only 90% are correct, still the administrative burden for a clinician and the fact that the clinician is reminded of the fact that something has to be done with these diagnoses will still help him. I do think the clinicians will forgive the 90%.
And that's also why we leave the possibility of adding something as a clinician. So if you're not happy, if you think, I really want to add this, you're still free to add it. If it's not in the letter, or if you're not happy with what has been presented, you can still change as a clinician. So we keep the human in the loop, as they say.
Okay, I have one more question. I'm a great admirer of problem lists, so I'm really with you in this. But one of the other problems that you mentioned, but I don't see a solution, is how you clean up. So how do you take out the diagnoses that are not longer relevant with this tool?
Yeah, so that's indeed a whole other dimension, and currently we call this tool the problem list manager. So we do really want to develop it into having these functionalities of being a cleaning up tool too. That's eliminating doubles, maybe taking out things that are no longer relevant, etc. So it's certainly within the scope of the project of the problem list manager, but it's not something which we have been able to perform within the first 3 or 4 months.
And the solution we have for that in our current TPD is that you have your own specialty file, and then you can say if something is relevant or not relevant in the history. So you can leave it available for other specialties, but just not that obvious for yourself.
Thank you very much. That is all we have time for the moment. Thanks once again to Mark and Elsa.